এখানে দাও স্লাইড শো from the beginning এ যাও from the beginning. Hello everyone, good evening, dear speakers, chairs and audience. I'm welcoming you to all to my presentation on transcatheter pulmonary valve implantation. Before that, I would like to thank the organizers for inviting me and Dr. Tawfiq for introducing me. So before going to the transcatheter, as the session already has completed about the valves, we noted that THV or transcatheter valves, these are applicable in 4 position: pulmonary position, mitral position, tricuspid position, and in the aortic position. So how the valve got damaged? There may be wear and tear, there may be calcification, there may be pannus formation, there may be endocarditis, and so forth and so on. And there may be also dysfunction of the already implanted valve. So the options for the tricuspid valves are, there are options for the transcatheter repair with the help of clip, with the help of annuloplasty, and there is the chance of replacement also with the help of orthotropic and heterotropic valve. For the mitral valve, mitral clip, then Pascal clip, then various types of valve like Tendyne valve, like Dragonfly. There are many valves available. And for the pulmonary valve, there are also many kind of valves available. Some of them are placed over the conduit and some are placed over the naked RVOT or dynamic RVOT. So if we see the curve, actually these are the disease of the adult, and mitral valve diseases are more common than that of the aortic valve disease. And actually these are very, very uncommon in pediatric age group. In pediatric age group, we deal with the pulmonary valve, which is not actually a replacement for the primary disease. So when does it start? It was started in 2020 when Professor Philip Bonhoeffer, he started to treat the stenosis and regurgitation in a prosthetic conduit in the right ventricular outflow tract. So these conduits are placed initially in the right ventricular outflow tract to treat some complex congenital heart diseases. So initially they were treated for the tetralogy of Fallot, for the truncus arteriosus, pulmonary atresia, double outlet right ventricle, transposition of great arteries, and even some of them had Ross procedure. And then there was dysfunctional conduit, or there was severe PR or TR and RV volume overload, and then this therapy was indicated. So my series is with the Melody transcatheter valve, and Melody valve, its indication is to extend the RVOT conduit life. Already there is a conduit there, so to extend the life of that conduit and to relieve the stenosis and to restore the pulmonary valve competence by relieving regurgitation. So what is the rationale? It helps reduce the total number of surgeries over the patient's lifetime, because dysfunctional conduit, even if you replace the conduit, it may become dysfunctional again and again. So there will be multiple surgeries in the lifetime. So this valve can reduce the multiplicity of the complex surgical procedure. Then it encourages even early intervention, and it is indicated in the patient implanted with the failed conduit previously. So Medtronic Melody transcatheter pulmonary valve it is actually Contegra type of valve, and it is a bovine jugular vein, length of which is about 28 millimeter. You are seeing here in the picture, and it can be trimmed down to 6 millimeter, and then again it is re-expanded. The same valve is re-expanded into 3 sizes by the 18, 20, and 22 millimeter size ensemble delivery system. So name of the delivery system is ensemble, and you are seeing here there are 3 ports. One is for the inner balloon, another is for the outer balloon, and another is for the wire. So this valve is inflated with the beep balloon. So what were the selection criteria? Selection criteria, as I have mentioned already, is the conduit dysfunction, and we should consider the weight, because 22 French delivery system should pass through the femoral vein. So weight should be more than 18, but we are now doing in more than 15 kilogram. Conduit originally should be 16 millimeter, and maximum RVOT should be 22 for this kind of valve. And exclusion criteria we are seeing here that active endocarditis, no venous excess, and unsuitable anatomy. So when we are going for selecting a patient, we should consider the age and weight of the patient, because these are small children, their femoral vein is very small. Even if we use the jugular vein, it is also small. So 22 French should pass through it, and we have to consider about that. And then we use for the device stability in the position of the pulmonary valve, we need some surgical history to know about the size of the conduit, type of the conduit, and etc. So what are the problems? You know that our country is like a developing country. Most of the patients, they are poor, from the poor socioeconomic status. So, and we don't even have CMR till now. So if we don't have CMR, it is very difficult to know about the RV volume, quantitative assessment of the RV volume and the PR fraction. And selection criteria was based only in my patient on the basis of the CT angiogram, echocardiography, and also by doing the RV angiography. And then another problem was arrangement of the valves, accessories, and other hardwares. You know, valve is not only enough, we need some covered stand, even some bare metal stand, and sometimes we need special kind of the catheter and supporting strong wires like Landerquist wire, which are not always available in our country. And funding of the valve is also a problem. I think our Indian friend will also give in this point. And in about the procedural challenge, as it is an infrequent procedure, because our surgical history is not so long. I have started in our country in 1998. So these are the post-surgical patients who develop this kind of complication, usually after 10 to 15 years of surgery. So in our country, surgical history is like 20 years. So in future, we will get many patients, and probably many of them will have money to do that. And suppliers' challenges, funding constant, infrequent procedures, so they are not interested to bring this, because they are the businessmen, and here business get little importance. And in my cases, another challenge was to motivate the parents. They know that it is a new technology, so they are not sure about the future outcome. And many of them are convinced, though, as it can avoid future surgery. So though the cases which I have done, only reason was they wanted to avoid the surgery. So I have collected the fund for this patient from the many charity project, and also from the corporate social responsibility fund. And to avoid the complications, I followed the strict inclusion criteria for this patient, and even for the difficult cases, I called the proctor. So we accepted our cases with the conduit dysfunction only in our initial parts. Many cases with the transannular patch and with the native dynamic RVOT, I have not included those cases, though they were in the need, but those are actually balloon, not balloon expandable valve, they were self-expandable valve, and I have excluded those from my series. Oops. So this is about my patient's characteristics. Age were about 9.5 years average. Most of the patients were female, 66%. And age of the patient at the time of first surgery were like 4 years. And then aortic homograft was used in most of the cases, 66% pulmonary homograft in 16%, and bovine pericardial valve conduit was used in 16% of the cases. Primary diagnosis was tetralogy of Fallot in 2 cases, and pulmonary atresia was the diagnosis in other cases. Slide maximum. So this is the result. PS gradient before the procedure, it was like minimum was like 45 millimeter of mercury and maximum was like 95. PR gradient, it was moderate. PR was moderate. It was quantitative, moderate or severe. And then RV and diastolic volume was more than 140 ml per meter square in all of the cases. And in association, there was absent LPA in one of the cases, RP and LP stenosis in 2 of the cases, and RP stenosis in 1 of the cases. And in the procedure, we have used general anesthesia for all the cases, and we have used CP stand as a landing station for this valve in most of the cases. Only in 1 cases I used Ender stand. And post-procedure, you are seeing that there is the gradient of the transpulmonary gradient was reduced in all the cases, and maximum gradient was seen 16 millimeter mercury in one case only. And PR was eliminated in all the cases. So my cases are in follow-up now. First case was done in 2012. So this is now 9 years of the follow-up. All of them are doing well. Last case is in follow-up now for 2 years, and they all of them are doing very well. Still now they're doing well with their valve, and no further intervention was required. This is my first case, which I have performed in 2012. This patient's primary diagnosis was tetralogy of Fallot with the absent left pulmonary artery we're seeing here. So we sent him for surgery, and tetralogy of Fallot repair transarterial approach was done in 2007. But immediately after surgery, he again developed complication. So these are the angiogram after his first surgical procedure. And then redo surgery was done again in 2009, and an orthotropic conduit was placed between the right ventricular outflow tract and pulmonary artery. And after second surgery, he again developed symptom within 6 months. And then in the echocardiography, we found that again there is severe conduit stenosis, and there is severe TR and severe RV. So his RV pressure was in the cath lab like 100 millimeter of mercury. And this time parent refused to do any more surgery. So I was trying to collect a pulmonary valve for him, and it took about 1 year for me to collect everything. And on 25th December 2012, we did this first case. You were seeing here the first case in the cath lab. This is the RV angiogram, APN lateral view. You were seeing that the conduit is here and it is a little bit calcified. So this is the calcified conduit here. And then here we are doing the measurements. And here we are actually dilating the conduit with a high pressure Atlas balloon. And at the same time, we are seeing also that whether there is any coronary compression. Okay, so this is here in the AP view. I am seeing again whether there is coronary compression. We are seeing that coronaries are far away from the balloon. And then in this case now, we are doing pre-stenting. So here is the calcification. We are trying to cover this with the covered stent. And you are seeing that it is a beating heart procedure. So during actually beat of the heart or during the cardiac output from the right heart, there is chance of little bit displacement of the stent during inflation, and this stent displays little bit towards the right ventricle. So we are placing another stent here to cover the whole length. So this is the second stent. Both of them are covered stent. And then now we are going to the implantation of the valve part. This is the valve you are seeing here. And this valve is placed inside a glutaraldehyde preservative. So we are now rinsing this valve in 3 saline baths. And then we are assembling it over the bib balloon of the ensemble delivery system. So this is now is the valve here. This one is the valve and these are the stents. So this valve is going towards the landing station inside the stent. So this is my number 6 case. I just want to show you some of the echocardiography. You are seeing here that this is the pulmonary stenosis of this patient. Pulmonary stenosis and pulmonary regurgitation. Here you are again seeing stenosis and regurgitation. So this is very tight stenosis you are seeing here. And there is severe PR also. So this is the gradient. And here we are seeing in the CT angiogram, especially CT angiogram is important in these cases to look for the coronary artery and the calcification of the conduit. So these are the glimpses from the cath lab of the second case. And this is a very important picture you are seeing here in this angio, that there is severe pulmonary regurgitation in this patient. Now we are dilating the right pulmonary. I have mentioned that one of our cases severe right pulmonary artery stenosis. So this one we are dilating with a high pressure Atlas balloon. Right pulmonary artery stenosis is dilated, and now this is the stent. So this is the case where I have used uncovered stent. This is a bare metal stent, Endra. So this is an XXL understand. And then now we are placing the pulmonary valve Melody inside this stent. And after placing this stent, now after placing this, so how beautiful this pulmonary artery angiogram is. We have used a multi-track catheter here to do this angiogram. And we are seeing here that valve is in nice position inside the stent and there is no pulmonary regurgitation. And this is the certificate of appreciation from the Medtronic Melody South Asia for the first ever implanter in South Asia. So in conclusion, percutaneous pulmonary valve implantation is an excellent treatment option in patients with RVOT conduit regurgitation and stenosis. Early result following PPBI has shown a significant reduction in the right ventricular pressure and gradient across the outflow tract. The most common complication is stent fracture or pulmonary regurgitation in the context of endocarditis. And we got excellent result in our series. We have performed 6 cases in that series and all are doing well. Last one is in follow-up for 3 years and first one is in follow-up for 9 years. And so PPBI has the potential to become the standard procedure in the treatment of dysfunctional conduit, even in the naked RVOT or paced RVOT, and will be easy to procure and will be easy to use in more and more cases if price is considered for the developing countries. Thank you all. Thank you for your patient hearing.
Assalamualaikum, madam. I'm Dr. Fazlur Rahman.
Walaikum salam.
How are you?
I'm fine. How are you?
Yes, madam, I'm fine.
Thank
is
you.
there any consideration of antiplatelet or anticoagulant in the implantation of
Yes,
pulmonary
yes. Yes, we give antiplatelet throughout the life. So antiplatelet aspirin is lifelong.
Yeah.
So we have to give lifelong aspirin therapy.
Yes.
Assalamualaikum, madam.
Alaikum salam.
This is Dr. Rizwana. Extraordinary
Yes, Rizwana.
presentation, madam. So
Thank
I
you.
have seen that the lowest age you have said that 15 years, 15 kg, lowest weight
Yes,
of your
yes.
patient.
Yes.
So for femoral venous hemostasis, what would you prefer? Is it suture-mediated closure or vascular pre-closure device or the regular technique?
Actually, in out of our 6 cases, in 2 cases we use Parclose, that is the closure device. But in rest of the cases we use a figure of 8 like suturing, and I found that that is very nice. And now I will never use Parclose again because Parclose is also we need to buy, and that suturing is possible with our silk and the needle only. So this is a figure of 8 suture, and that is very effective. And in our last 4 cases, we use that mechanism in this series.